I just wanted to start really by showing you a quote from Dame Cicely Saunders. Those of you who don't know who she is, obviously she founded the hospice movement, and she actually died at St Christopher's, so she was a patient. And what we're trying to get across is that we only have one chance to get this right for patients at the end of life, and that's what we're trying to do for patients and their families. And this is obviously a report in 2010 about, you know, how patients die and really what patients and families think about healthcare at the end of life, and what we're trying to achieve is to make things better for people. Does everything have to be difficult? Well, no, it doesn't have to be difficult. The service that we're providing is a new service. We're an independent health company working with an NHS provider, which hadn't been done in end of life before. So you can imagine that we had quite a few challenges in the beginning from the NHS, from the acute, from the community. And our success really was because we went out there to engage with people. That my team and myself came from an NHS background. We have experience in end-of-life care, and we could relate to what the NHS and what the community were going through. Things are fragmented between health, social care, and especially around benefits. And that's what we've tried to do, is to pull things together, is that we work across boundaries. This has been taken from one of our patients. She hadn't actually had a close relationship with her family, but she needed some support because obviously there were some signs of neglect. Nobody was going in to see her because she hadn't got a particular need, she hasn't got a nursing need, she hadn't got a clinical need as a specialist need. So she was quite lonely and isolated, and we actually picked her up onto our service so that we could monitor this lady, we could give her support, we could find out what her needs were, what her wishes were at the end of life, and we could then refer her on to other agencies when and where it was appropriate. But also the important thing was around navigating those difficult services that patients and families find really difficult at this really stressful time in their life. I don't know if any of you have had to do that as a family member. I'm not talking about a professional. I think when you have somebody in your family who is going through a terminal illness, you're not there as the professional, you're there as the family member, and it's just as difficult for us at that time as it is for anybody out there in the public sector. And so therefore we're there to try and navigate those difficulties for patients and their families. So what did we do? We helped her with some of her social problems, you know, getting somebody in to actually come and do some housework for her, which is, any of you that work in the community will find it's very difficult to try and get somebody in as a cleaner. We don't have home helps as we used to many years ago when I was a district nurse. We helped with her appointments, so one of our coordinators actually went with her to her appointments, to the hospital, to a GP, so that we could then go back and we could share, you know, what she felt about what was happening, what she interpreted as what was being said at her appointments. We also helped her with things like managing her finances. Also, our service looks at anybody or takes anybody onto the service in the last 12 months of life, regardless of their diagnosis. We are a nursing team, but we're not a hands-on team, so that those patients who are in the last 12 months of life but haven't got a nursing need and aren't picked up by any other service group, we will pick those patients up onto our service and we will follow them through their journey until they die, and we will pick up their families and provide them with some signposting for bereavement services. But also, although we're not a hands-on service, we are there to recognise when patients start to have symptoms. I have a team of 15 coordinators who've all got a vast experience in end-of-life care, from hospice to oncology. We have nurses who've worked very much intensively with COPD and respiratory, diabetes, and also a couple of nurses who've worked in the acute, so that we've got a vast knowledge of skills that we can pull and also recognise when patients start to have difficulties, so we can refer patients on for OT. We've got a very strong links with physios and OTs, and we can get quicker referrals into those services when and if patients need them. As I said, our service is about enabling patients to make choices. So it's interesting that some of these patients who are in the last months of life have never had the opportunity to sit down and discuss what they really want, where they want to die, what's important to them, what sort of things do we need to put in place for them before that happens, or before it's too late to actually act upon that. Our service was set up to look at unavoidable admissions at the end of life and readmissions, and statistically, patients in the last 12 months of life will spend 3 episodes in an acute hospital. In our first 12 months, we were able to reduce that to 1 admission for the patients who are on our service. It's about providing 24/7. We have a hub which is called our Care Bureau, which is a nursing triage system. Once a patient's on our system, our notes are all electronic and so in real time, so that once a patient is seen, those records are uploaded onto our system. So whenever a patient phones, and whatever problem they haven't got to go through all their past history over the last 10 years or so, because our nurse has that information in front of her. The nurse will answer a phone within 30 seconds. There's no answer phones. A patient will go directly through to a nurse and can talk to her about any situation at all.